So what I thought, what I was asked to speak about is the Ontario experience on assisted PD. And I think it's, you know, I'm a little bit ashamed to say that if such a program is implemented at a provincial level in Quebec, I must say that I hope that you do a better job about documenting outcomes and really tracking the data and information than we did in Ontario. And things sort of evolved, and I was talking to some people yesterday, and I said the really frustrating thing with governmental initiatives is, you know, somebody thinks something's a good idea, and it is, and it gets implemented across the province, and it either works or doesn't work, but you don't really have a way of measuring it because it hasn't really been properly evaluated. So I'll tell you what we know about assisted PD, I'll tell you what we don't know, and then I really want to actually have a discussion about what people's thoughts are about assisted PD in Quebec, some of the challenges, and have a sort of a, I guess the whole point of today is a roundtable discussion on issues in home dialysis. So this talk really, I think, hopefully will generate lots of discussion. And the other thing I should mention is that Matt Oliver is one of my colleagues at Sunnybrook Hospital who probably has more experience with assisted PD than I do. We work very closely together, and I'll share some of his thoughts as well. And I just wanted to upfront thank him for his support in getting this presentation together. But this is one of my patients. Just to give you a patient that I saw, an 89-year-old woman, Canadian-born. She lived alone. Her son lived in town. Her daughter lived out of town. And as it is with many families, like the son was kind of more involved and on the ball. The daughter was a bit loopy and kind of came in and out. Her not necessarily the gender, just her ESRD was suspected due to chronic GN. She never was biopsied. She had a history of a hysterectomy with a midline scar, and she had stage 5 CKD and was seen in pre-dialysis clinic. And this is not her, but she really liked to go to casinos, so I thought I'd put that picture up. So she lived far from a hemodialysis facility. She had mild to moderate cognitive impairment. She still enjoyed outings with her friends, and in Ontario it's Casino-Rama. I drove by a lovely casino on my way over here, and so I'm sure there's similar ones here. And the patient and her son was referred to and educated about home dialysis, and she was kind of keen on home dialysis. So some of the questions are, what are the potential barriers to home dialysis in this patient? Would you consider peritoneal dialysis in this woman? And if yes, what resources would you feel comfortable to have in place before doing so? So let's just have a discussion here. So what do people perceive as some of the barriers here for home dialysis for this person? I know everybody in this room is going to put her on peritoneal, but let's just... Age. So, right, so her cognitive capacity, she's going to be able to do the peritoneal dialysis exchanges. And I think also one of the things I'm always concerned about is when I hear about previous surgery, what's the placement of the catheter going to be like in somebody who's had previous abdominal surgery? So that's a concern. And then, of course, you know, what are her living conditions like? So we all kind of get a feeling that she may not be able to independently do dialysis, peritoneal dialysis on her own. And so, you know, then the question is, can some of this be overcome with resources? If I gave you $1 million to do PD in this person, what would you be able to put in place to facilitate that? And so, you know, we'll talk a little bit about that, and that's really what today's talk is about. Can we implement resources to allow PD to take place at home? And this is what this nephrologist said. This was not my patient in pre-dialysis. This ultimately became my dialysis patient. And the quote is, and this is from an email that I received, whenever home PD is deemed safe, in quotation marks, a very relative term, I always let the patient choose. But in this case, I think an 87-year-old living alone with no immediate supports close at hand would make me lose sleep. And that's not an unfamiliar sentiment, I think, for many nephrologists about this patient. And, you know, I think it is a very reasonable thing to think about concerns about this patient being at home. So with that in mind, we'll define what assisted peritoneal dialysis is. We'll discuss the development and rationale of assisted PD in Ontario from a historical perspective. I'll kind of tell you how it came to be in Ontario. We'll talk about existing outcomes regarding the use of assisted PD, and we'll really hopefully discuss and share unanswered questions, controversies, and future directions. So assisted PD, what is assisted PD? Well, I just wanted to show this picture. This was the very first assisted PD patient that I ever looked at and looked after. And this was the patient. He's still actually on PD, so he's been on PD for 4.5 years in our program. This is the home care nurse that came and set up his machine every day. This is our dialysis nurse, Ramona, and this is me. And what I wanted to do is accompany Ramona, our home dialysis nurse, on a visit with the home assisted nurse. And this is really a meeting that happens usually when patients start PD. So he was one of my first new PD patients on assisted PD. And we're just doing the first home visit with the home care nurse who's going to be responsible for hooking the patient up. So assisted PD is identifying and training an individual other than the patient to perform dialysis-related tasks. And with regards to peritoneal dialysis, I think that these are the tasks that we need to think about. Cycler connection, so connecting the cycler, cycler setup, cycler disconnection, CAPD exchanges if the patient is on CAPD, and vital sign, weight, and treatment monitoring documentation. So this is the whole constellation of activities that might be involved with an assisted PD nurse. And you know, when we talk about who can provide assisted PD, well, many of you don't know it, but you have a lot of patients already on assisted PD. And because, you know, spouses and other family members, you know, to varying degrees participate a lot. Paid caregivers by the patient, so a lot of people may have caregivers already because of their cognitive decline or functional decline, and these caregivers assume additional roles by assisted PD. But we're talking really about, you know, visiting healthcare professionals, which could be nurses, home health aides, or other health professionals. And today I'm going to focus around nurse-assisted PD. But really all of the above people are people that participate in assisted PD. And then lastly, another way to think about assisted PD is training rehabilitation centers, retirement homes, or long-term care facilities to be able to provide PD for patients. So, you know, what are the elements of assisted PD? Your target population really is patients who have barriers to self-care, patients who can't or you don't feel comfortable with managing their own care. I don't know that this is the target area to work in. I don't know that this is so feasible in a rural population, because if you have patients who live very far apart from each other, the resources you require to consistently make routine home visits might be very challenging. So again, another word of caution in my mind is if you're thinking about a pilot program in Quebec, I would definitely focus on your ideal pilot area is an area with a high population density and a lot of elderly patients. You want high density elderly patients. The assistants are nurses or nursing assistants, and we talked about some of the tasks. And really the funding, you know, in Canada and Ontario, it's funded by the CCAC, which I'll talk about. But in many jurisdictions, PD programs themselves have funded assisted PD, or industry has come in and funded assisted PD for a particular jurisdiction. So there's been a whole host of different funders in the models of assisted PD. So I showed this slide earlier. This is just to update. It's not as pretty as the other one because I wanted to show you the updated data to 2012. But I just want to show you again, these are the patients that were dialyzed. The majority of patients that we're dialyzing in Canada are over the age of 75. So this is a problem of, dialysis has become a problem of care for the elderly. And I don't think any discussions about nephrology that don't take into account geriatrics and aging are comprehensive discussions, because we really need to think about how are we going to best suit the needs of this population, because this is the population that's grown and this is the majority of our dialysis patient population. And this was the landscape when assisted PD was first thought about or talked about in Ontario. This was the curve of the way things were going. And you know, this was an era when now the elderly patients on dialysis were increasing in incidence, and we needed to think about some solutions for elderly patients on dialysis. And you know, it's all over the news that we have this baby boom population that are really sandwiched between elderly parents and children. And I came across this story on CNN. This is Joan London, who's a very famous American reporter, and it really is that caregiving for loved ones is the new normal for boomers. So all these 75-plus-year-old people have children in their 40s and 50s from the baby boom, and they're the ones that are going to be responsible for looking after and caring for them. And thinking about ourselves getting older, we have to think about how we would want to be cared for. And this really hits home because I see my mother in that situation, looking after my grandmother, who's elderly, and it really is quite a burden on the whole family. And I was in a supermarket the other day, this is no joke, the supermarket parking lot near my house. And this Cadillac drove up with the license plate that said caregiver. So I thought, yeah, well, that's exactly what our society has become for many people. So it really is an ongoing issue. And I'm not joking, it really is in my local supermarket parking lot. And you know, at the time, what was happening to the changing landscape of incident dialysis modality in Ontario? This was a time when hemodialysis was increasing in frequency and peritoneal dialysis was declining. So we had an aging population and a decline in the use of peritoneal dialysis in Ontario. So in 2006, what happened is the Ministry of Health and Long-Term Care of the province divided the province into 14 regions, which I'll refer to as LHINs, Local Health Integrated Networks. I think there's a similar regionalization in Quebec of different regions from speaking to people yesterday. And in April 1st, 2007, the LHINs really took on the full responsibility for health services in their communities. And so these are the LHINs in Ontario. And you can imagine, like LHIN 14, like how is an assisted PD program going to functionally work in a LHIN where, you know, the geographic area is bigger than most European countries? It's very challenging. And then you have more densely populated patients in LHIN 6, 7, and 8, which are in Toronto area. So again, you can see that the LHINs each have their own challenges. And Dr. Oriopoulos, who was my colleague and mentor, wrote a paper and had a vision. If we're developing these LHINs, you know, let's work towards reversing decreasing peritoneal dialysis in Ontario. And so he wrote a huge detailed paper on how we could increase PD use in Ontario to 30% by 2010. Unfortunately, we did not achieve those numbers in 2010, but it was a whole tiered plan to work with the Ministry of Health called the PD Initiative. And Dr. Oriopoulos was passionate about PD, and so much so, he was a Greek nephrologist that once we reached the 170th PD patient at UHM, we were all taken out for dinner to this big Greek restaurant. This was us at the Greek restaurant, and this was Dr. Oriopoulos telling us all how proud he was of the program and growing the program. So he was very passionate about this initiative to grow peritoneal dialysis. And this was the Provincial PD Initiative, which was a joint initiative between the community care access centers, long-term care centers like nursing homes, and chronic kidney disease branch of the Ministry of Health. And the whole idea was that patients were going to be encouraged to be treated at home, and that people didn't have to choose between treating their patients with PD and hemo, that we were going to have a whole mandate in the province of sort of a home-first policy. And so the goals of the initiative were to have 30% prevalent Ontario dialysis patients on PD by 2010, and 40% if your home dialysis center had an established home hemo program. So sort of a 40% all-home target or 30% PD target. It was to increase patients' choice to choose home-based therapies, to encourage retention on PD for as long as possible, and to have a consistent and standardized process to deliver PD across Ontario, and more services for PD patients across Ontario. And it was a very big, lofty goal to achieve all of these things. But one of the things that was put in place were agreements between home care. So there was a whole division of the Ministry of Health called Community Care Access Center that delivers all the home care in the province, nursing homes, and chronic kidney disease centers to really provide a mutual solution. And just to show you, you know, this target now, when you go to the ORN website, they still target that very same 40% of new dialysis patients on an independent therapy. They've changed it now to within 6 months of initiating dialysis to give people sort of 6 months to get their act together in their programs if patients have started hemo. But you know, these are, this is the red bar here, in case you're all wondering. My hospital is over here. But this is the red bar, and you can see that the vast majority of programs are not hitting this target. So it's this target. I'm not sure where the target came from. We can talk about if a target is appropriate. But again, there's many programs that aren't. And it tends to be programs that have significant challenges where to meet this goal, particularly around delivery of PD and access-related issues. So this committee, PD Coordinating Committee, was put forth together. There were sort of six branches: retention branch, a data management branch, a branch that worked on PD training, staff and education, that worked on guidelines, pre-dialysis education, and assessment of patients. And really the issue here were the partnerships between the Community Care Access Center and the long-term care facilities was really under this umbrella. So the plan was to have one long-term care facility per LHIN to provide assisted PD in nursing homes. And the plan was to have the Community Care Access Centers to work with providers within the LHINs to provide assisted PD, and I'll show you what that means. And the CCACs actually subcontract nursing providers within the LHIN to provide assisted PD services. So the CCAC was going to provide support and teaching to ease the client transition. The CCAC calls patients clients from hospital to home, and ongoing nursing and personal support workers for clients who are medically appropriate for PD or don't have a primary caregiver to assist with the PD in the home. And if you did have a primary caregiver, it was for respite and support for primary caregivers. So this is how the delivery of assisted PD in Ontario really works. You have the CKD program, which could be a PD facility. You have CCAC that coordinates all of home care services. And you have the home nursing providers. In this case, it's St. Elizabeth Healthcare, VON, Paramed is another company. All these little, they're companies that the CCAC develops contracts with. And these companies trained nurses to provide peritoneal dialysis, and these were the nurses that went to the home to deliver the peritoneal dialysis. So you can see there's a lot of arrows here. It's the patient with the nurses from the nursing provider, the patients with the CCAC coordinator, the programs with the patients, the nurses, and the CCAC coordinator. So lots of areas where communication has to happen to make this successful. And so just one of the largest providers in Ontario is St. Elizabeth, and they've been providing in-home PD for 27 years. They're the largest provider in in-home PD nursing service, and about 400 active nursing staff are currently have training in PD. Now let me tell you a backstory. I knew about this talk 3 to 4 months ago. I emailed every possible person that I knew to get a number of patients on assisted PD in Ontario. That's what I thought I wanted to present today. These are the number of patients we've trained on assisted PD in Ontario. And I could not get this information, either because they didn't want to give it to me or they hadn't been collecting it accurately. And the only place I could get this information, at least is from the St. Elizabeth themselves, who maintain their own internal database. So they were kind enough to share their database results, which they also shared at one of our independent dialysis meetings. So they're the largest providers. So this doesn't represent all of Ontario, but it probably, I would guess, and don't quote me on it, about 70% of assisted PD in Ontario. So you can see these are the number of clients that they had at any given time on assisted PD in Ontario, and these are the number of dialysis visits. So visits during the year to provide dialysis for these patients. So in 2013, they provided 27,061 visits. And that's probably about 70% of assisted PD in the province. And what you can see here is that there's huge variation in their client distribution across the different regions in Ontario. Part of that is because they may not be the main contract service provider in that area, but the other part of it is that when you go to areas that are very remote, like Simcoe or Muskoka, these are much bigger geographical areas, and so it may not be possible to provide assisted PD the same way it can be provided in a more urban area like Toronto Central. And so basically the pathway is that there's a referral from the CKD program to the CCAC case manager. They receive the referral, they talk to the contracted service provider agency like St. Elizabeth Health. They review the information, and then there's a home safety assessment. There's a personal support worker that works with the patient, and a nurse that provides service to the client that does the tasks of assisted PD. And this is sort of the process that one goes through to get delivery of assisted PD in the province. So what have been the challenges with this? So it's about, working with the CCAC and working with these providers. So these are some challenges that I've observed just as a consumer from a nephrologist perspective of these services. I think one thing I've noticed is that there's different perception of the care needs of the patient between the CCAC, the service provider, and the CKD center. So a lot of the times we'll find out that the assessment by CCAC and home care is that this patient no longer needs assisted PD. And that's probably because the patient has become comfortable with the therapy, but then you see them in clinic or you review them and you're not so happy with their technique. And so it's a push and pull between the CCAC and our CKD program as to trying to continue to get them to come visit. And again, just because somebody's comfortable with their assisted PD, doesn't necessarily mean they may not need assistance. And this has been one challenge, carving out what the appropriate level of supervision is and when to start and stop the services. Another challenge has been it's been very difficult to maintain and audit competency of the CCAC nursing providers. So there's really limited accountability and the lack of data and outcomes. So if I want to know what's the peritonitis rate compared with this provider versus X provider, I can't really get that data. It's not collected. If I want to look at outcomes based on providers, we really have no accountability between providers. The retraining of the staff has not really been the mandate of the centers. Each of those programs have done their internal training, may or may not have had involvement with industry training. And there's really been some limited coordination of practices between the center and the CCAC staff. So if you think about it, if you're in a LIN and St.Michael's Hospital does their dressing this way, and Sunnybrook Hospital does their dressing this way, and this is how we like to have it, and this is how Sunnybrook likes to have it, it's the same CCAC provider in that LIN. So how do we standardize a process that's comfortable with all of the hospitals? And then the other thing is really how to maintain skills is really left at the discretion of the service providers. The other thing I think is a big challenge is that there's really limited to no availability in remote and rural locations. And that's not just assisted PD. I would probably argue that that's home care services in general. And then there's a limited and variable communication between the nurse and the CKD center. So I have one patient. I'm always happy when she comes to clinic because her assisted PD nurse named Michelle writes me a very detailed note. And I read that note and I respond back to Michelle with a similarly detailed note. But of my 20 assisted PD patients, she's the only nurse that takes the time to send me a detailed report about how this patient is doing. But shouldn't that be the standard? Shouldn't we be able to, in this day and era of emails and faxes and Blackberries and iPhones, not be able to log on and utilize these nurses to fully maximize the communication capacity? So just some words to you guys as you're on your journey here. And then patient dissatisfaction. So patients like their home dialysis nurses, they develop a relationship with them. In our center, we tend to have a primary nurse, primary patient model. I don't know how that works in other centers. But they get really angry when that nurse doesn't show up, or if it's a different nurse, or if it's 10 different rotating nurses. So the changes in the nurses support team really can impact the success of your assisted PD program. And an 80-year-old woman does not really appreciate a 10 o'clock at night visit to set up the cycler. So again, there's challenges there, and sometimes the visits are at suboptimal times of the day. The other criticism I've heard is, why am I sitting at home a whole day to wait for this nurse to come to set my machine up? Wasn't the whole point so that I could be free during the day and do whatever I want? So we have to work on some of these challenges. So it's not all doom and gloom. I just think you should probably know about some of the challenges in addition to some of the triumphs. So in terms of the new transition, this is something that I found out actually just by doing this presentation. Nobody decided to tell me or the nephrologists. But on April 1st, the funding for assisted PD is going to change in a couple of days. And it was previously under the purview of the Ministry of Health and Long-Term Care. And now, many of you know this renal body called the Ontario Renal Network, like the British Columbia Provincial Renal Agency, will receive all the CKD funding in the future, and that will all basket through them to the programs. They're going to take over funding for assisted PD, and they're going to provide the funding to each of the CKD programs. And the CKD programs are going to decide, do we like this model of nurses going out to the homes from these service providers through CCAC? And they can continue to keep the funding flowing the way it has, or they can decide on a whole new model of delivery of PD. If they want to hire nurses from their facility to do all their assisted PD patients, they can. And so I'm curious to see how this will change the direction of assisted PD in the province. So that's a little bit about where we were and where we're going in Ontario. What about the outcomes of assisted PD? So you asked me to speak about assisted PD. Let's talk about why you asked me to speak about assisted PD. So what are the potential advantages of assisted PD? Have more patients. So increasing peritoneal dialysis utilization, because we all think that that is a good thing to do. Increasing quality of life in elderly patients.
Decreasing the burden for the family.
Okay, so decreasing the burden for the family.
It's more of a question, cost effectiveness compared to in-center dialysis.
Cost effectiveness compared to in-center dialysis.
Transportation is decreased.
Transportation, yeah, so great. So we want to improve PD utilization, I heard that. And that might mean put more new patients on, like we talked about from the last talk, and keep patients on longer. So reduce death, reduce permanent transfers to hemodialysis. We talked about this now, improving the patient, caregiver satisfaction, quality of life, and functional abilities, right? We want everybody to be happy, not just the patient, but the patient's family and the whole care team. We want to reduce adverse events or remain neutral. So if you are putting a patient on PD you're concerned about, we want assisted PD to reduce hospitalizations, reduce infections and adverse effects. And Dr. Vizina mentioned travel. I think I would put that here, but you're totally right. Like, that fits into keep people happy and don't make them drive in bad snowstorms. And remain more cost effective. So if all of the above criteria are met, then it should be more cost effective. So if we can improve outcomes more than the incremental benefit of the costs, perhaps it can be more cost effective. So this is why we're here today talking about assisted PD. These are the metrics. These are the reasons you want to know about assisted PD. So these are the things that need to be evaluated in my mind to demonstrate whether the cost and the infrastructure that we're investing in assisted PD is going to be worth it. So question 1, does assisted PD improve PD utilization? So this is really sometimes how it feels like working in a PD clinic. A revolving door. You have a constant influx of new patients and you have a constant egress of patients from your program. And sometimes it can get very challenging. And this is the revolving door of PD treatment. You have your new patients that are new cases of end-stage renal disease or patients who transfer from another modality. And then these patients, as I talked about in the first talk, can die, they can be transplanted, have a permanent modality transfer or recover. So this is the equation for PD utilization. You have to either increase this or decrease this. And in decreasing this, you really want to decrease death, decrease permanent modality transfers, and increase the number of new patients. So these are the players we have to focus on individually to look at with assisted PD. So does it improve PD utilization? The first question is, does it improve the number of new patients who start PD? So this is what it takes to get a patient from no dialysis to peritoneal dialysis. And this was articulated by Matt Oliver. You have to identify a patient with end-stage renal disease. You have to formally assess every patient for PD eligibility. You have to offer them peritoneal dialysis. Once you offer it to them, they have to choose peritoneal dialysis. Once they choose peritoneal dialysis, you have to attempt a catheter. And like we talked about in the previous talk, the catheter has to be successful. And from catheter insertion to step 6, they have to start PD therapy. This is the equation. Any one of these faults or is impacted, you're not going to successfully initiate a patient on PD. And you have to identify patients, we have to educate patients, and we have to facilitate. The other thing is that how patients choose PD is a balance between barriers and incentives. So whichever way the scale tips is how patients are going to choose PD. There are certainly barriers. These may be unsurmountable barriers like contraindications to PD, like abdominal surgeries or inflammatory bowel disease, medical conditions and social conditions that make PD absolutely contraindicated. But then there's the sort of ones that we all debate and are worried about, the potentially modifiable ones relating to the ability to perform self-care dialysis, so cognitive decline, psychological issues, physical issues, and then there's patient fears and preference. So some patients are really scared of doing dialysis on their own. Some patients are really scared of feeling isolated. And these are some of the barriers. But then there's the incentives. There's the travel, the work schedule, people who live far from a facility, mobility. So the same patients who are unable to care for themselves are not really going to be very portable to and from the hemodialysis facility with ease. Sometimes a very significant fear of blood or needles drives the decision for PD. Not because the patient particularly wanted PD, but they were scared out of in-center hemodialysis. And we all know those patients who've chosen PD for those reasons. Diet and fluid liberalization, and also flexible scheduling. So you can see here that sometimes, with a fear barrier and a couple of incentives, you can sort of tip the scale one way or the other. And the question really is, can these barriers here, the fear, the ability to perform self-care dialysis, really be overcome with assisted PD? And that's really the question about the number of new patients. And so if you look at a very systematic evaluation of new patients starting dialysis, these are what people marked as the medical contraindications. So you can see here, this is data from the Dialysis Management and Reporting System from Matt Oliver's database, which we contributed to at St. Michael's Hospital. You can see abdominal scarring, obesity, hernias. These are the reasons medically that people feel PD may be contraindicated. But if you look at the barriers to self-care, again, one of the more common barriers is that just no strength to be able to do the peritoneal dialysis exchanges or lift the bags, or no manual dexterity in the majority of patients. As far as cognitive barriers, there's language barriers, concerns about compliance. So you can see these are some of the other barriers to self-care that aren't medical conditions. What do nephrologists think? So this was a study that was done by David Mendelsohn, really surveying nephrologists, saying, why don't you think PD is more prominent than you feel it should be? And what nephrologists said is that, well, we're dialyzing older and frailer patients. And so they felt that that was one of the, more nephrologists felt that was a major barrier to PD than any of the other reasons. So again, we're dealing with people who are increasingly having barriers to self-care, which comes with aging. And so again, another study looking at 940 consecutive patients across 3 programs. Again, 40% of new patients have a physical barrier to peritoneal dialysis. 37% of patients have a cognitive barrier, and the caregiver burden was not assessed in this study. And so really the framework for PD eligibility is you have potential PD candidates who have these barriers, and really, if they can't be overcome with support, then they're not eligible for PD. If they can be overcome with support, they may be eligible for PD. And so we really need support to overcome barriers. And you all have seen families step in when the patient can't, a caregiver step in, patients transition to a nursing home where PD can be provided or assisted living. And then here's where home care fits in. Can home care help overcome some of these barriers? So, this was a study that was done when home care was rolling out in Ontario. Two jurisdictions were compared with each other. One where assisted PD was available, one where assisted PD was not available. And what you can see here is these were 83 patients starting dialysis where assisted PD was available, 51 starting dialysis with no assisted PD. A little bit younger in the region with no home care, a little bit more male. Similar levels of pre-dialysis care, similar levels, a little bit more in-hospital starts here. And then was on a median of 3 barriers that people had in the region with home care compared to 2 barriers with no home care. And 80% of patients here were deemed eligible for PD if they had assisted PD. And here only 65% of patients were eligible for PD. So the eligibility, who you would consider for PD with assisted PD, went up when you had a home care support. And 59% ended up on PD. So remember, you have to be eligible for PD and you have to choose PD. So among the people who were eligible, 59% chose PD and 47% ended up on PD, whereas 58% chose PD and 37% ended up on PD. So again, when you look at eligibility for PD, with assisted PD, there's no question in this study that eligibility for PD goes up when you have assisted PD, and the receipt of PD goes up. But remember, it's not all about assisted PD. The patients still have to choose it, and they still have to be informed about all their treatment options. So the gains really here is when they receive PD are not as exciting as the eligibility gains. And that's why I think we need to be very systematic about how we look at PD utilization. And then we put out a survey. This is going to be published in Peritoneal Dialysis International by a summer medical student of mine. And one of the questions we asked is lack of assisted PD a major barrier of growth to your program? And this was across Ontario, where the more rural areas and some areas don't necessarily have consistent PD. And you can see here about 40% of patients, physicians said that it was a major barrier or a barrier to assisted PD, not having assisted PD in the province. But again, assisted PD can take the form of home care or family. And again, this is just showing you when you have a physical barrier to PD or a cognitive barrier or both, family support increases the eligibility for PD. And if you choose PD, again, if you have a physical barrier, cognitive barrier, a physical and a cognitive barrier, you tend to choose PD more likely with family support than without. So family support is really key. Home care support may add an incremental value to that. So that's kind of the data for, does assisted PD improve PD utilization in the sense of new patients? But the other thing is that a lot of the times you feel a patient doesn't need assisted PD, but they're scared or they're fearful and they don't want to do peritoneal dialysis at home by themselves. Sometimes assisted PD in our pre-dialysis clinic is the carrot that gets the patient to consider PD when they wouldn't have considered it before. And they train, and there's that fear factor of doing dialysis on your own. So what I can't quantify in this data is how many patients are fearful of doing dialysis on their own, and having and encouraging nursing support in place might get them to reconsider. Because if you tell a patient who's scared, we have a program in place where a nurse will come to your house up to twice a day, help you, guide you, help set up your dialysis in the first while. You can choose to keep them, or you can choose, if you're feeling more comfortable, to discontinue them, and then that really helps. And I had a 70-year-old Portuguese-speaking woman who was totally frightened about doing dialysis on her own. She did assisted PD, she did CAPD. She didn't want to do APD. She was pretty adamant about it because she was scared of the cycler. So she did assisted PD with CAPD. They came 3 times because she started off on 3 CAPD exchanges, so home assisted PD came. And I got a call from the nurse, what do you want me here for? I'm basically come here to watch this lady do her exchanges. Because she had learned through the assisted PD nurse how to do her own exchanges. And what we have not done a good job of quantifying in Ontario is how many patients do we have that graduated from assisted PD, that started off not confident, assisted PD was provided for a period of time, and then they became confident to do their own dialysis. If you think about it, that's the most cost-effective way of delivering assisted PD, because it's not this never-ending assistance. It's assistance for a period of time. And assisted PD was developed with that goal in mind. Could we use it as a bridge therapy? And we haven't done a good job about quantifying some of those outcomes. So does it improve prevalent PD utilization? So now we've talked a little bit about increasing eligibility. We talked a little bit about eliminating the fear factor, which we haven't quantified. Let's talk about death and transfers to hemo. We have 0 data in Ontario about technique failure, up until PDOPS maybe, about technique failure or death with assisted PD. Now it's a little bit difficult because who are you going to compare an assisted PD patient to? A PD patient who doesn't need assistance? Well, that's an apples to orange comparison. What you really want to do is compare an assisted PD patient to a patient who's on hemodialysis who would have been eligible for assisted PD if it were available. But I don't think that comparison is going to be easy to find in the literature. So the best data we have is from the French Peritoneal Dialysis Registry from Thierry Lobedez and Christian Verger, who looked at the incidence of events on assisted PD versus self-PD. And again, I just wanted, well, that didn't come out so well, but I just wanted to show you that assisted PD at 2 years, only 15% of patients were transferred to hemodialysis versus 21% on self-PD. And again, if you look at, again, they did a competing risks analysis as well, looking at death and technique failure, so they did it the right way. But again, if you look at the hazard of transfer to hemodialysis, in fact, family-assisted PD did not have, was not statistically significant from self-PD. But again, if you look at nurse-assisted PD and assisted PD with a completely independent group as a reference, there tended to be lower rates of technique failure. So again, I'm not sure the comparison is appropriate, but it certainly doesn't suggest that assisted PD is associated with higher rates of technique failure. If anything, slightly lower, if not similar. So this is, I think, helpful, and it really shows us that you can increase technique survival with assistance. So that's really the only data we have on technique failure. And I can tell you that the delivery of assisted PD in France is very different than Canada. So we need to know that answer here in Canada and Quebec and Ontario. The next question is, does assisted PD improve quality of life? Right? That was one of the things that we wanted to know about. The answer is, I don't know, because nobody knows. And the other question is, what's the comparator group? Is it a patient who chooses no dialysis and opts a conservative care pathway? Is it a patient who goes on to PD without assistance? Or is it a hemodialysis patient, but somebody who was eligible for assisted PD? I don't really know. We probably should make all three comparisons because patients have to make a choice at a point in time, and they probably should know the impact of their choice with all of these three groups. This didn't come out very well at all, and I apologize for that. The only data I can provide you on quality of life is to say, well, what's the overall quality of life for elderly patients on peritoneal versus hemodialysis? Because that's the group we're interested in. So this came out of Edwina Brown's study in London, the Imperial College. This was the broadening options for long-term dialysis in the elderly study, which was looking at the quality of life in PD versus hemodialysis in the elderly. And on past, there seemed to be better physical component scores in the PD group versus the hemodialysis group. And this data is not here, but PD patients tended to be more satisfied with their cares. So it wasn't a slam dunk for PD, but certainly patients on PD felt better physical component scores of their quality of life score. And there's certainly much more comprehensive ways to measure quality of life. But at least for PD, it suggested that PD may be an option for dialysis in the elderly, and it may be associated with similar, if not improved, quality of life in certain domains. The other thing people talk about is peritonitis. So all I could do is really pull out the studies that have looked at assisted PD. The Vergère experience in France had 1 in 36 episodes per patient month for assisted PD peritonitis, which I think is pretty good. And they, in their study, was similar to self-care, but it was actually worse than family-assisted PD. So something to keep in mind. In China, the experience of peritonitis was 1 in 55 patient months, but the Chinese have unbelievable peritonitis rates. And there was no difference between assisted PD and self-care PD. In 2 Taiwanese experiences, different centers, 1 in 24 patient months and 1 in 25. Here it was higher than family-assisted or self-care, and in this comparison, there was no difference with self-care PD. And then recently, this month, published out of Brazil, 1 in 37 patient months with assisted PD in Brazil, but they didn't compare that peritonitis rate to independent PD patients. So again, I don't think that there's this huge signal here of greater peritonitis with assisted PD. The other thing is that I recently contributed to a manuscript that the American Society of Nephrology was writing on palliative delivery of dialysis. And one of the things that we can think about assisted PD for is rescue or palliative therapy. So patients who have exhausted vascular access may have no other options than assisted PD. Or patients who are hemodynamically unstable for hemodialysis, like severe heart failure, may not be able to do any other modality but assisted PD. So it may be a salvage therapy for many patients. And you know, if somebody has a poor prognosis, some patients would choose assisted PD over palliation if in-center hemo was the only other option. So some patients may not be offered dialysis because of palliation purposes, but assisted PD may fill a gap for those patients. So the next question is, what are the costs of assisted PD? So this is the raw numbers here. And again, it took me a while to get this data. I pushed for it. If you have 2 visits per day, 365 days per year, the going rate per visit, what the CCACs pay these St. Eliz or the other nurses agencies is about $50 to $65 per visit. This is variable. Don't quote me on it. It's sort of a rough estimate. And it's about $43 per year. So this is the incremental cost if you have an assisted PD patient on 2 visits a day, 365 days per year, which probably surpasses, if not is equivalent to in-center hemodialysis. But you have to take into account what we talked about, which is you have to look at the golden group of patients, the ones that you can get graduated from assisted PD that only require it for a short period of time. And again, if you look at all patients, these are all patients on assisted PD. These are the proportion of patients who were able to graduate from assisted PD and be completely independent. And that's really, I think, one of the main goals of assisted PD. So I call that sort of bridging assisted PD. And when you look at that through the study by Matt Oliver, what drives cost is really the number of visits. So you can't think about it as everybody gets 2 visits a day, 365 days per year, because the additional operating cost, when you looked at the actual data, was about $12,000 per patient year. Here it's about $50 a visit during the pilot program. And again, the average visit, the average patient only required, on average about 5 to 6 visits a day. Here it's around a little bit more than 6 visits over follow-up per week. 6 visits per week. So that 14 visits per week is the max, but you have to look at what people are actually using in terms of visits per week. So again, if you look at that, all comers to assisted PD tend to use assisted PD with around 6 to 7 visits per week. And that's where the costs really lie. So you really have to look at it from that perspective. And if we think about the incremental cost per patient, the margin that we have between in-center and PD per patient, this is around $28,000, this is around $40,000. We still have an extra $20,000 or so to play with to catch up to in-center hemodialysis, and here we're only at $12,000. So again, we don't have robust cost-effectiveness analyses, but I wouldn't throw it out of the ballpark as not a cost-effective therapy until we have better data. And again, this is the situation we're in. In Matt's study in Ontario, the average patient age was 76 years. In France, the average assisted PD patient is 79 years. In China, 71 years. And in the Netherlands, 77, or Denmark rather, 77 years. So again, this is providing dialysis options at home for elderly patients who may not have otherwise dialyzed at home. So back to the case. This patient initiated in-center hemodialysis. In the winter months, she had a fall getting out of Wheel-Trans. This is our our public transportation for functionally impaired patients that delivers patients to hemodialysis. So she actually had a fall getting out of Wheel-Trans to hemodialysis. Hip fracture, she had a GI bleed followed by a myocardial infarction. She went to rehab for several months. She came back and she was still interested in peritoneal dialysis. She had 9 lives, this lady. And the patient was transitioned to a retirement home because she could no longer live on her own because of all of this. And we really worked to find a retirement home that would work with home care. So we looked at 5 homes, and every retirement home said, no, we're not interested in a patient on peritoneal dialysis, but we finally found one. She underwent a laparoscopic PD catheter, given her history of hysterectomy. We trained the patient, the son, and the retirement home staff. And she received assisted PD for 2 years, and she was very pleased with the decision. So much so that the son sometimes took her to the cottage and was able to do dialysis with her. And then 2 years later, she had ischemic bowel and received palliation and passed away peacefully. But at least she had 2 good years of quality of life, I think, on assisted PD. So, what are some of the unanswered questions with assisted PD? I showed you a sort of comparison, which was a very small study of a region that had assisted PD and didn't. But on a population level, on the macro level, does assisted PD improve PD utilization? Remember, we're targeting a very elderly population to increase new dialysis starts in an elderly population whose time on PD just inherently is going to be very short. So that might not necessarily at a population level pan out to increasing PD utilization, but we don't have data to support that. And now, if you look at PD utilization in Ontario, again, I asked for what the proportion of modality was for patients age 75, and I wasn't provided it. I wanted to look at that distribution to show you if on a population level we're seeing more PD in age 75 plus patients in Ontario. But I would bet you that we probably haven't seen a huge spike in PD utilization in Ontario because of assisted PD, but it is one small piece of a very complex puzzle. Is assisted PD associated with improvements in quality of life, patient satisfaction, and life participation activities? Again, we need to know what the quality of life of patients are on assisted PD compared to other therapies, and I'm hoping PDOPS will at least help us collect some of that data. Are the costs of assisted PD as a bridge therapy offset by the avoidance of facility hemodialysis? Again, a more rigorous following of the patient journey and looking at what's the number of patients who get bridging assisted PD and how many patients did we avoid in-center hemodialysis on is really critical to this piece. And is assisted PD a cost-effective therapy? Well, to talk about cost effectiveness, it's not just the cost of delivery of hemo and the cost of delivery of PD, but we need to look at, well, what are the hospitalization rates and what are other markers of healthcare utilization? If the PD nurses are spending more time and energy and are dealing with more hospitalization episodes with assisted PD patients, it may offset some of the cost effectiveness. So this is the data we need to really make these conclusions. So thanks very much.